Hi, everyone. I'd like to welcome all of those who are joining us for the first time today and everybody who's coming back to join us again after watching our September and October events. I'm your host today, Mark Hennick. We have participants who are joining us today from all across Canada and, in fact, all around the world. So I'd like to take these opening moments to acknowledge the lands on which we're conducting this event today. These lands include the traditional territories of many nations. Canada Health Infoway recognizes that the many injustices experienced by Indigenous peoples of what we now call Canada, it continues to affect their health and well-being every day. Canada Health Infoway respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. So I'd like to invite all attendees here today to reflect on the territories you're calling in from as we commit ourselves to gaining knowledge, to forging new culturally safe relationships, and to contributing to reconciliation. I'd like to make a very brief note about myself and why I'm hosting here with you today. For those who have joined us previously, you may have already heard this, but for those who are new especially, I like to remind everybody that when I engage in these kinds of conversations, especially conversations with respect to health innovation and digital health and making healthcare more accessible to all, I always ground it in my personal patient experience. I've had the great privilege to work as a clinician and as a policy influencer in the mental health space, but I think, as we say in the mental health space in particular, nothing about us without us, that we need to have patients at the core, at the center of everything we do. And that's why I'm so excited to do events like this, which help to ensure greater access for all to not only mental health care and services, but healthcare and well-being services more broadly. Now, I'd like to pass it over to the Honorable Patty Hadju. She has a message that she's prepared to us, and we're going to play that message for you now.
Bonjour. Je suis heureuse d'avoir l'occasion de me joindre à vous virtuellement aujourd'hui pour parler de santé numérique, une question de plus pertinente à l'heure actuelle. A year ago, talking about virtual services as an integrated part of care in Canada would have been, sadly, aspirational. But COVID-19 has changed all of that. The world is a much different place now, and the need for digital solutions in healthcare is crystal clear. C'est également la semaine de la santé numérique, ce qui constitue un bon moment pour faire le point sur ce qui s'est passé au cœur de 9 derniers mois et réfléchir à l'orientation que nous allons prendre. Après tout, il est indéniable que cette période a été favorable aux initiatives de santé numérique. Before I go any further, I want to recognize the work that Canada Health Infoway has done to advance digital healthcare in Canada. Infoway has been championing this cause for a long time now, nearly 20 years. I acknowledge your ongoing hard work to move the yardstick forward in an area as challenging as digital health. And you've laid the groundwork for the progress we are seeing today, and we all owe you our debt of thanks. As you know, everything changed last March. The COVID-19 pandemic has turned digital health from a nice-to-have to a must-have almost overnight. Public health measures to contain the pandemic made it very difficult to continue in the same old way. It's never been more important for Canadians to have accessible health tools and resources, from reliable information and alerts to mental health supports and screening tools. Nous n'avons eu d'autre choix que d'être créatifs. Puis, de manière assez inattendue, nous avons découvert une souplesse que nous ne savions pas que nous avions et avons trouvé des solutions à des problèmes anciens et nouveaux. They say that necessity is the mother of invention, and that is certainly the case here. During the pandemic, we've had to pivot quickly to virtual service delivery to ensure that Canadians can get the basic care that they need. Provinces and territories acted quickly to implement temporary billing codes that allow providers to treat patients virtually. And as a result, most Canadians are now able to have an appointment with their doctor by phone or video conference in the safety of their own homes. It is a solution to a short-term challenge, but it has a great potential for the future. We have an opportunity now to make lasting progress by adopting digital solutions that will see us through this pandemic and beyond. Il s'agit d'un investissement qui en vaut la peine. C'est pour cette raison que le gouvernement du Canada collabore avec les provinces et les territoires pour les aider à accélérer leurs efforts relatifs aux soins de santé virtuels. En mai dernier, le Premier ministre a annoncé un investissement de 240 millions de dollars pour soutenir la mise au point de services virtuels et d'outils numériques dans le domaine des soins. Of this, $150 million is going to the provinces and territories over the next 18 months through bilateral agreements to expand their digital efforts in areas such as secure messaging and video conferencing, online access to lab results, and remote patient monitoring. Up to another $50 million is going to Canada Health Infoway to help provinces and territories implement these new initiatives. As a result of these investments, we are helping Canadians access the health services they need through virtual channels, such as telephone, text, or video conferencing. And of course, this includes supports for mental health and substance use. These tools help reduce pressure on the healthcare system, and they also allow governments and health service providers to make evidence-based decisions, both crucial advantages during a pandemic. La période que nous vivons est très déroutante pour la plupart des Canadiens, et aucun aspect de nos vies n'est épargné. Recognizing this, the Government of Canada has developed its own suite of digital tools to help Canadians navigate some of the very specific challenges of the past 9 months. This includes challenges finding accurate, reliable information about the pandemic. Every internet search, no matter the topic, yields a flood of information, some of which is misleading or false, and it's not easy to sift through it all, and in a pandemic especially, it can be dangerous. So we developed the Canadian COVID-19 app early on to serve as a trusted digital source of information on COVID-19. It includes everything you might want to know about COVID-19, including a dashboard of daily statistics and a list of resources, including a self-assessment tool. Now, ArriveCan is a little different. As you may be aware, all travelers are required to submit specific information when entering Canada to comply with border measures and limit the spread of COVID-19. The ArriveCan app and its website are secure, user-friendly tools that reduce wait times at the border, limit contact with others, and keep travelers and Canadians safe. These are two examples of how we've used technology to share and collect information. But digital health is much more than that. People can and are receiving support through these technologies. Le portrait Espace Mieux-être Canada offre gratuitement à tous les Canadiens des services de soutien en matière de santé mentale et de toxomanie. Les services offerts comprennent une auto-évaluation en ligne, de soutien par le pair et de la consultation par message texte ou par téléphone pour n'en nommer que quelqu'un. Services are provided in both official languages, and instantaneous translation is available for phone counseling in 200 languages and dialects. The portal is funded by Health Canada, and it's managed by a consortium of organizations who have experience providing digital mental health and substance use support services, including partners like Kids Help Phone, Homewood Health, and Stepped Care Solutions. It's never been more important to reduce barriers to access and make these services widely accessible to Canadians, given the mental and emotional toll of living through a pandemic. And digital technology allows us to do that. So far, more than 530,000 Canadians have reached out for support through Wellness Together Canada. Enfin, je tiens à vous parler de notre application Alert COVID. Cette application sert à alerter les utilisateurs en cas d'exposition possible à la COVID-19 et permet aux personnes ayant obtenu un résultat positif au test de dépistage d'aviser les personnes avec qui l'on eu des contacts étroits. I want to emphasize that this tool was designed from the ground up with privacy in mind. The system is highly secure and does not collect or store any personal identifiable information. The Office of the Privacy Commissioner of Canada has reviewed the app and supports its use by Canadians. In fact, the Commissioner uses it himself. Jusqu'à maintenant, l'application Alert COVID a été adoptée par 8 provinces et a été téléchargée plus de 5 millions de fois. This is an example of how we can integrate new technology, such as a mobile app, to support existing mechanisms in our healthcare system. With careful thought and consultation with experts, privacy concerns can be addressed. I think this is one of the most important lessons of the past 9 months. With creativity and cooperation, we can overcome challenging obstacles. S'il y a une bonne chose qui ressort de cette pandémie, c'est la façon dont les Canadiens se sont mobilisés pour y faire face résolument, ce qui comprend tous les travailleurs du système de santé. The COVID-19 pandemic has been a catalyst for adopting new delivery models and other innovations. We've achieved things in the past few months that might otherwise have taken years to accomplish. There is no better example of how working together across sectors and jurisdictions can get results. Les solutions de santé numérique continueront d'être essentielles au cours des mois à venir, alors que nous apprendrons à vivre avec le COVID-19. Au fil du temps, elles deviendront une partie intégrante de nos vies et notre système de santé n'en sera que plus solide. Merci.
Thank you so much, Minister Hadji, for that wonderful message. I think we can all agree for the need for digital healthcare, especially now. Now, Canada Health Infoway would like to acknowledge the critical role of patients, as I started by saying right off the top. Patients, families, and their caregivers contribute so much to the care system in Canada. And Infoway is committed to collaboration as they work in improving the healthcare system. So the following statement shall ground us in our discussions and remind us of our responsibility toward patients, toward families and caregivers as well. So on behalf of Canada Health Infoway, the statement reads, Canada Health Infoway recognize the unwavering commitment and essential impact that patients, families, and caregivers have and will always have on the Canadian healthcare system. Canada Health Infoway pledges to continuously listen to the perspectives and learn from the lived experiences of patients, families, and caregivers to ensure respectful collaboration in the work they do and influence. Canada Health Infoway looks forward to building true partnerships and acknowledging shared successes. Now, one of such initiatives that fosters such partnerships is called the Patients Included Initiative, or I'm sorry, Patients Included Charter. Now, Infoway is pleased to continue to convene events which adhere to the accreditation. The Infoway Partnership Fall Series Patient Advisor is Anne O'Riordan, and I've mentioned several times before on the last couple that we couldn't have done this, I think, without you. She's been involved in the planning and the program, so a sincere thank you from the team at Canada Health Infoway for your continued support, Anne. It means really so much. Now, before I move on to the first session in the agenda, I have just a few quick notes that I'd like to cover. First of all, the Infoway Partnership Fall Series have been made possible due to partnership within the industry itself. And this is really incredible to see. So on behalf of Canada Health Infoway, thank you to the Alliance founding sponsors. Thank you again to the wonderful sponsors. Now, we're going to be looking for your feedback throughout the event today by using some polls. So the polls, the online chat moderator will let you know when those are going to be live, and you're going to see this slide appear a few times. So really, please do participate in those polls. They really do help us to get a temperature on what people are thinking. Now, we'd also like you to engage with your fellow event attendees right over there on the chat, on that side or that side, whichever way I'm mirrored here, in the platform chat by connecting via the attendees list. And we're going to do our best for questions. So we want to try to include as many of you as we possibly can. But in order to stay on time, however, we might not be able to get to everybody's questions. So we'll do some at the end of each presentation, time permitting. Submit them in the Q&A box on the right. You can also upvote questions that you want to move to the top, and anything that we don't get to, we're going to come back later in the email, or at least as much as we can. All right, now let's get to the program. It's now my pleasure to introduce the next session, or our first full session. So I'd like to introduce now Jane Holden. Jane is the Executive Director of Special Projects with Canada Health Infoway. And Jody Shanoff is the Vice President, Consultation and Engagement with Environics Research. Jane and Jody, over to you.
Thank you for joining us this afternoon. I'm Jane Holden from Canada Health Infoway. Let's get started with some background on our national public consultation, which we entitled A Healthy Dialogue. We believe that A Healthy Dialogue is one of the largest national public consultations on digital health ever held in Canada. We conducted the research from fall 2019 through to summer 2020, and we reached over 58,000 Canadians. A Healthy Dialogue is part of a larger initiative that Infoway is conducting that is looking at the future of Canada's health system 5 to 10 years down the road, focusing on emerging technologies and other trends that are on the horizon and likely to shape that future. We all know that the health system exists to serve Canadians. So understanding what Canadians want and expect from their health system is extremely important to any consideration of its future. So the results of A Healthy Dialogue will be an important input into this bigger initiative that's looking at the long-term future of the health system. Last summer, we kicked off the project by engaging Environics Research to conduct the consultation on our behalf. And now my co-presenter, Jody Shanoff, will describe that to you.
Thanks very much, Jane. I'm very pleased to be here this afternoon and to be able to discuss the results from this very large, very significant consultation. If we look at the overview, what we had the opportunity to design with Canada Health Infoway was a multi-phase, multi-channel consultation activity, a mix of quantitative and qualitative inputs to collect information, to be inclusive and to give an opportunity to those who might not otherwise find themselves at a discussion table like the one we were convening for this consultation. And we took great care to use tools and approaches that could meet Canadians where they were so that they could provide their input. We'll be focusing during the course of this presentation on the quantitative survey parts of the consultation, but there is much rich qualitative feedback from the different groups of Canadians and residents who contributed to the effort. When we move on to just looking and focusing on the methodology for the surveys, we took, again, great care to design a very robust respondent profile of for our national surveys. The first wave, which took place in late fall and early winter 2020, involved almost 7,000 Canadians in a quantitative survey, 6,100 of whom participated through online, and the balance were contacted by telephone in areas of the country where online contact couldn't be made in a reliable way. So in particular, speaking to residents up in the territories by telephone. The coming about of COVID-19 suggested that we should go back out and measure some more attitudes and behaviors, that the environment we were looking at had changed quite significantly, and we were all curious to understand what kind of impact that might have on attitudes and behaviors among Canadians when it came to digital tools and digital health tools specifically. So the second wave of the survey needed to be a little more nimble than the first, and involved closer to 2,200 Canadians who were recontacted, having participated in the first wave. It was a sample that was representative of Canadians across the country, oversampling groups like Indigenous populations, Canadians with chronic diseases, and even caregivers. I'll hand it over to Jane now to talk more about some of the findings that we got.
Thanks, Jody. So it won't surprise you to hear that Canadians are avid users of technology. In our survey, 85% say they shop online and 74% manage their money online. Interestingly, there's an even greater appetite for technology in healthcare. A whopping 92% want technology to make healthcare as convenient as the rest of their lives. Canadians care deeply about their universal health system, and 93% told us they want it to keep up with health technology advances that have happened in other countries. But 75% of Canadians say they're well aware that healthcare is behind other sectors when it comes to technology, maybe because they've noticed that doctors' offices, pharmacies, and hospitals are the only places they see fax machines anymore. Not surprisingly, 80% of Canadians think investments in healthcare technology should be a top government priority, particularly to address the first order challenges that they care most about, like quality of care, access to care, reducing wait times, and making sure that people who live in remote or rural areas have similar levels of care as people in large urban centers. Beyond those first order challenges, we discovered that Canadians find it difficult to think big about the future of health technology. Even after we showed our focus group participants a pretty visionary video from Kaiser Permanente about a hyper-connected health system, and then we prompted the participants with follow-up examples, they still had a really hard time thinking futuristically. Just as an example, at one focus group that I observed last September that Jody was facilitating, when she asked them for people's ideas about the future of technology in healthcare, there was a really long silence until somebody finally piped up with a story about how their brother-in-law's neighbor or some such distant connection had had a video call with their doctor. And the others in the focus group reacted as if he was describing something out of Star Trek. Of course, that was back then, pre-COVID, and wouldn't seem so space age now. Let's move on and talk about what Canadians think are the benefits of health technology. So, having recognized the convenience and empowerment that they've gained from technology in other areas of their lives, Canadians can see that technology could bring them similar benefits in healthcare. 90% of them want technology that gives them greater control of their health, which is interesting because it contradicts the traditional picture of Canadians as somewhat passive recipients of healthcare who have just become accustomed to waiting a long time for whatever the health system gives us without us feeling like we have a lot of say in the matter. Canadians think that technology could be a real game changer. 86% say they think it can solve many of the issues in our healthcare system. And in fact, for many Canadians, the benefits of health technology are not just theoretical. They directly experience those benefits themselves. 8 in 10 who have used healthcare technology in the past year say that they were better able to manage their health and reported a better quality of life. 53% were able to avoid an in-person visit to a healthcare provider or an emergency room. And 40% were able to avoid long-distance travel outside their communities to get healthcare. For underserved and marginalized groups, including Indigenous people, it's about a lot more than convenience to them. For them, technology represents an opportunity to close the gap between their healthcare experiences, which are frequently negative, and the experiences of other Canadians with the health system. People that we interviewed during this project expressed the hope that technology could contribute to greater equity and less systemic bias and discrimination when it comes to getting access to healthcare. And now I'll pass it to Jody to tell you about some of Canadians' concerns about healthcare technology.
Thanks very much, Jane. So not surprisingly, just as Canadians were prepared to acknowledge many of the benefits of health technology, they also expressed concerns and issues that serve as barriers when it comes to adoption of the technology we were proposing to them and the advances we were proposing to them. There were a few different types of barriers, the most significant of which manifests itself in concerns regarding privacy and security of our personal health information. Canadians need assurances that protecting this personal information is going to be a priority, and it is the main barrier that gets in their way of picking up some of the tools that can be available to them. Now, we did see a shift from one survey to the next when it came to the acuteness of this concern. So it declined from 78% down to 74%, but still, by and large, the most significant barrier according to Canadians. Adding on to comments that Jane offered earlier about marginalized and underserved Canadians, access to personal health data was also a concern to the extent that many of these groups worried that this information could serve to further marginalize them within the health system. And so a requirement of assurances that that would in fact not be the case. And ultimately, while there was comfort and even tolerance for involvement of private sector organizations, Canadians look at the government to be the ultimate steward of this type of technology and the steward of the privacy and security of their personal health information. Other barriers that emerged from the research, we tended to categorize them, excuse me, as either social and systemic barriers or technological barriers. So in this case, social and systemic often pertained to somebody's demographics, their regionality within the country, even the social determinants of health that impacted how they were able to interact with the healthcare system. So we see in particular Canadians who don't understand health information, who don't have access and aren't familiar with apps and tools available to them. And then more on the technological side, a not insignificant number of Canadians who report that they don't have access to reliable internet service through which they would be able to access some of the tools that we spoke of with them. However, ultimately, when we weigh out these barriers and benefits and concerns, we still see that a majority of Canadians, and this is at the end of the second survey, 63%, still see that the benefits outweigh the risks when contemplating the use of digital health tools. A little more on the impacts of COVID-19 and how it impacted the results of survey from one wave to the next. As I mentioned, we wrapped up the first wave of the consultation in late February and realized that the world had changed quite significantly, and this presented an opportunity to determine the extent to which significant changes in how we function on a day-to-day basis might be impacting people's behaviors and attitudes when it comes to digital health tools. In particular, our increased reliance during our period of isolation and quarantine, increased reliance on technology in general for commerce and communications, as well as restricted access to healthcare services. Overall, the experiences that Canadians reported to us that they had during this period were very positive when it came to accessing healthcare through virtual care tools. The pandemic really laid bare for Canadians that digital health tools provide opportunities to access the health system in the future, especially when they're hindered by something like a pandemic. In addition, there was much willingness expressed when we conducted the survey in June to access virtual care tools, whether or not a Canadian had had that experience during the pandemic. Those who had the experience generally had a very positive experience, regardless of the channel or the tool they used. And those who hadn't clearly had heard good enough stories and feedback to not dampen their willingness to access virtual tools in the future when they might need them. I'm going to hand it back to Jane now to talk about what's next for Canada Health Infoway.
Thanks, Jody. So where do we go from here? Well, we are communicating these findings pretty broadly over the next couple of months to a variety of audiences, including a social media campaign to reach the general public. We'll be sharing the results with FPT governments, other health sector leaders, clinicians, patient organizations, and so on. I mentioned at the beginning that we have this emerging technologies and other trends initiative that's looking at the health system of the future 5 to 10 years away, including how Canadians will interact with that future healthcare system. And our objective is to identify what we as a country can do now to get ready for that future. The findings from a healthy dialogue are going to be an important input into that project, and that project will complete in the very near future, the next few months, and so we'll have more to report on that in Q1 of 2021. So in this brief presentation today, we've only been able to skim the surface of the findings. I invite you to go to ahealthydialogue.ca for more information, where you can download the executive summary if you would like and request a copy of the full report. On behalf of Jody and myself, I'd like to thank you very much for your time and attention today. And if there is some time, we'd be happy to take a question or two.
And thank you so much. Jane Holden is the Executive Director of Special Projects with Canada Health Infoway. Jody Shanoff is the Vice President of Consultation and Engagement and Environics Research. I think we do have time for two very short questions here. And right off the top, how many languages, could you tell us, was the survey or the initiative offered in?
I'm happy to jump in on that, Jane. The survey was offered in French and English, but through other channels of the consultation, there were other languages involved. In particular, focus groups with Indigenous peoples were often done in their native language when we went into the communities.
Great, thank you. Now, we know that the pace of technology often far outpaces policy. You know, there's some estimates that knowledge translation can take years, in fact. So somebody here is asking if the survey provided information or details on the willingness of Canadians to make some trade-offs, you know, between access, convenience, risk, perhaps. Did you draw out any of that kind of information?
Did you want to answer that, Jody, or?
Sorry, Jane. I thought I'd let you.
Okay. So we didn't ask people that specific question, what trade-offs are you willing to make? But one observation we did make is that when we were having the focus groups and we got to the very important section on risks versus benefits of associated with healthcare technologies, we take the pulse up front and see, how did people feel? Did the risks outweigh the benefits, or was it the other way around? And what we found without exception is, even though people started out with a fairly high degree of trepidation about potential risks, as the discussion progressed and we got further into what the benefits were, vis-a-vis health technology and their relative value compared to the potential for risk, unanimously by the end of all of those discussions, and I think we had 16 of those discussions online across the country, and then 10 more with Indigenous communities in their own communities. Without exception, they always came out on the end of, yeah, the risks are real, but the benefits definitely outweigh the risks.
That's fascinating. I think we could probably have a whole separate discussion about the adoption curve of these types of things. Unfortunately, we don't have time to do that. And we did get lots of other questions. So please, everybody, pay attention to the wrap-up communications that you'll be receiving at the end of the week. We're going to come back with some more of those great questions. Jane and Jody, thank you so much again for joining us today.
Thank you. Pleasure.
Thank you.
Now we have a quick poll for your thoughts that's running there for you. Please take a moment to take a look at that and answer that for us. And now we're going to move directly into our next presentation. So on the agenda, we're going to welcome Sheila Maloney. She's the Executive Vice President of Marketing and Engagement from Canada Health Infoway. She's going to come on the screen here, as well as her panelist, Dr. Ewan Affleck. He's a Senior Medical Advisor, Health Informatics with the College of Physicians and Surgeons of Alberta. Sandra Cascaden is Associate Deputy Minister of Digital Health, Analytics and Privacy with the Department of Health and Wellness in Nova Scotia, my original home province, so hello to the East Coast. Victoria Marchand is the coordinator at the University of Ottawa's Indigenous Resource Centre. Matthew Jackson is the patient coordinator at the Centre of Excellence on Partnerships with Patients and the Public. And Evgeny Lukapoudis is the Chief Technology Officer and the Digital Technology Supercluster. That's a whole lot of people with a whole lot of expertise, and I know I'm looking forward to hearing from them. So welcome to everybody.
Thanks, Mark. I think I'll take that as my cue. Welcome, everybody. And I think we've got a great number of panelists, as Mark said, lots of things to talk about. And I think Jody and Jane's session was a great precursor to the conversation that we're going to have. Clearly, virtual care has taken the world by storm. Out of necessity, it's keeping people safe these days. We've heard the benefits that Canadians are feeling about the technology and the concerns of that Canadians are feeling about technology as well. So today we have a number of different perspectives on our panel. We've got a government, we've got industry, a couple of clinicians. Victoria is also a nurse that wasn't mentioned before, Matsur from a patient perspective. And so what we really want to talk about today is sustainability of virtual care. First of all, do we want it going forward? And secondly, what do we need to do from the panelists' different perspectives to make it a reality and to make it an effective, appropriate, and viable option for care? And I want to be clear, and we had this discussion a little bit, is that when we say virtual care, we don't think that virtual care is going to take over from everything else. It's not the only option, but we're talking about it as a viable mode of delivery in addition to face-to-face care and other care that might be available. So without any further rambling from me, let's get on to the panelists and let's hear different perspectives. And Sandra, I'm gonna start with you. You're in the provincial government in Nova Scotia. Curious about how you and your colleagues are thinking about this. I know when we talked last week, you described this as a live experiment. So what are your thoughts in terms of, and what's keeping you and your colleagues excited? What are you excited about, and what's keeping you up at night?
Great. Well, thank you very much, Sheila. Certainly, absolutely, without a shadow of a doubt, I think that virtual care and digital health have a place in the whole model of care. There's no doubt about it as we move forward. As you said, I think what we've just gone through has been an interesting experiment. It's created a bit of an artificial environment in which we are benchmarking the adoption of virtual care against. I think that we certainly have a number of learnings from everything that we've gone through in the past number of months, and we continue to go through, because none of this is over, right? So we continue to gather our learnings, we continue to gather observations. We certainly know that we have a lot more work to do, okay? So I think we have to make sure that when we're embracing the virtual care as part of model of care, we have to understand what's the quality of care that we're providing, what's the appropriateness of each type of session. How are we dealing with patient choice, provider choice about whether it's a virtual care session? What are the patient experiences? Have we really settled on the fee codes for providers? Standards from colleges and other professional organizations we still have to work through. Evaluation is hugely important to understand, are we delivering what we need to deliver to patients, as well as what's the experience for the providers as they're trying to combine this into their whole model of care. Change management and education around this, how to conduct a really good session, what's your role as a patient, what's your role as a provider. I won't go through all of the barriers that were just presented, but they're real barriers. Those barriers are whether it's digital literacy, it's access to the internet, all of those types of things. So, but having said all that, and the fact that we have more work to do. I think what we've learned is we should be embracing this and now moving faster. No longer should we be doing it at the same pace that we did this before. And all of those things we should just be doing a whole lot faster. So I think it's here to stay. We have to make sure that it's done in an appropriate way. We get good quality of care and we provide good services through virtual care. And how do we just really embed this in the model of care? Thank you.
That's great. Thanks, Sandra. Evgeny, I'm gonna jump to you. As I think one of the things that Sandra said about moving faster, and clearly industry is right along with this ride, and being part of the Supercluster, you know that better than anybody. So interested in your comments around the ability to move faster when it comes to virtual care.
So first of all, thanks for having me on that panel. As you know, the Digital Supercluster is an industry-driven association. So we actually have focused on investing in a lot of projects around digital care. And of course, we are not investing in solving the problems immediately of today. We're looking a little bit ahead. So it's more of an innovation that is bringing new opportunities, which I think virtual care and digital health and the pandemic actually has opened for us. And we take a broader view. So for instance, I would say virtual care for us and for our members has not been only the efficient collaboration and communication between a patient and a provider. It's more than that. I mean, you have also the provider-to-provider communication. So practically, how do you help a rural physician that has a difficult case? And there has been projects, for example, that are having a network of intensivists that provide this care on demand for rural physicians that actually have to deal with very, very urgent cases. So specialized care in the rural community. Even just think about point of care ultrasound. It's a trouble. It's only being able to be served into provider centers that are concentrated into the big cities. So can you enable a rural physician with the help of even AI to be able to do specialized diagnostics with ultrasound, for example, or in some critical care like dermatology, you know how quick the prognosis for melanoma change. There have been very, very interesting projects around that. I would like to mention one because it's not only the provider-to-provider, it's also the patient-to-patient. There has been a lot of patient-to-patient support. Maybe many of you remember the old network of Patients Like Me, which was acquired by United Health Group very recently. There is a Canadian version actually of it. There is a Curation Networks group that the Supercluster has a very interesting project with them, which combines, of course, not only remote monitoring, but also peer-to-peer access where patients actually help each other. And don't forget that there's a dimension of not only talking one-on-one with a provider to a patient or provider to a provider or patient to a patient, there's group settings. Curation, for example, has peer groups that they have created a very interesting mechanism of delivering disease programs directly to those patient groups. And it's the human touch. I mean, you create an environment in which not only your peers can participate, but your family, your guardians, your custodians, the people that actually care for you and the family can also participate in that group. So we have been looking more for the opportunities that it gives that actually will increase the patient engagement, will move the virtual care to a level which is not at all secondary care. It is actually something which might be even primary. It certainly will be something that will be preferred in remote communities. And we mentioned indigenous and very rural settings that are having challenges today, but it breaks boundaries and also breaks the boundaries between the different legislations. I mean, even within one legislation today, these things become possible, but why not tomorrow doing it across the country? If you think about physiotherapy, for instance, and is the problem that this is provided across the country. Pain management is a serious condition that needs a very, very long term care. So these are the things that we have seen a lot that our industry has picked up from the crisis, and it's actually accelerating pretty fast.
Yeah, thanks. I think it's really interesting in terms of breaking down the barriers and the acceleration pace. And I want to bring in Victoria and you, and so Victoria, you represent sort of the Indigenous communities, and you work in remote areas and provide care. And so curious about your sort of feedback, and Mathieu too, because I think one of the things that when we talked last week, you were especially interested and keen on the human touch. And so, Afghani talked about that, and as virtual care as a mechanism to potentially even extend that, because you can bring in other members of your family and not just you one-on-one, depending on where they live. So maybe you and your thoughts.
Yeah, thank you, Sheila, very much. And again, as Afghani said, it's a privilege to have been invited to join this panel. Yeah, I have lots of comments. Sandra really provided a breakdown of many issues that still stand in the way of coherent virtualization. And and Afghani has painted some options with respect to the technology that can support us. There's an interesting observation out of British Columbia. Now, just so people know, I've spent, as Sheila said, my entire career working in the Arctic and subarctic. I look out the window, there's Yellowknife out there and snow everywhere, and working with Indigenous populations for 30 years. I'm in the hospital right now on service and just on a break. So my involvement in virtual care and in digital health technology really goes back to the start of my career, when it became very clear that there are massive inequities to people living in remote communities in northern Canada, and how can we use technology to deliver better care. And that really is the seed that planted my interest. And what's interesting is 30 years ago, when my journey started, was about the time the World Wide Web was invented and digital technology became an opportunity. And when you look at Northern Canada, we really have not changed substantively in terms of how we continue to function. The phone is largely the technology we use. There is a little video conferencing, but for the most part, we're reliant on internal combustion engines to move patients, and there's really been a very slow adoption of coherent virtualization. Now, COVID has changed the interest, certainly, but there's an interesting observation out of BC a few weeks ago, and that is with the shift to virtual care with COVID, what they are seeing is a disinclination for physicians and other providers to go to the communities now and just to rely on virtualization. So it can't, I could not agree more with Sheila. This is not, this needs to be an option for care, but should not replace core continuity of care with the providers that you know. And there will be and that is something that we as a system will need to combat. The digitization of health services needs to be soundly designed or founded upon the provision of quality care. Continuity of care drives quality, and with virtualization, there's an opportunity to fracture that. So for me, the issue is really this, there are manifold and profound, and I've spent my career trying to promote virtualization in remote and rural Canada. However, the problems that I see is there is a profound lack of literacy at all levels. We do not design systems to provide the value proposition. The value proposition of virtualization or digital technology is information. It is not the technology. And yet we continue to purchase technology without designing or reimagining how we as human beings interact around it. So we are largely not interoperable. We have analog management systems, we have analog ways of behaving with each other, and there is a conflict between that and the digital technologies. And so as a result, there is a big problem. The lack of human, and Sandra made reference to the regulations and standards and so forth. I could not agree more. Often it's not the technology that's the problem. In fact, virtually all the technology one needs to provide coherent virtual care is sitting on this phone. I'm not saying we have to use the phone, but the technology is the easy part. The reason we fail in Canada is we have not reimagined healthcare. We are working with analog management, oversight, ways of behaving interprofessionally, and so forth. And it is impeding our capacity to use technology in a coherent manner.
Great point. And I want to bring in Thierry on that point as well. First of all, though, Victoria, I'm just curious about your thoughts around some of the comments that Ewan made, and particularly around sort of rural and First Nations communities. And I should say that as part of the survey data that Infoway does, 26% of Canadians have said they do not have reliable enough internet to allow for virtual care, and 42% said they don't have the digital literacy skills to understand the health information they gave. So curious about your perspective, Victoria.
Yeah, absolutely. So first of all, I just want to start off say Victoria Indigenous Kiragan Thibi Nidonjba, Mongol Nidodam. So using my Anishinaabe lens, it really is important to touch upon those equity issues first and foremost, and realize that the healthcare system, inclusive to the digitization or virtual care, is built on the premise of assimilation tactics, right? And so we need to really understand that these systems were built to perpetrate violence and more harm on Indigenous people, and continues to do so today in very subtle ways. So absolutely, like I agree, the levels of digital literacy are lower, but so are our access to higher education. So are the access to different programs and services that could kind of provide better literacy skills and better access to healthcare, or better means of taking care of oneself. And so I think we do need to acknowledge those systemic barriers, right, that we face at all levels. And Indigenous people, specifically First Nations status people, but also Inuit beneficiaries, they have a really unique place in Canada, because we are children of the state, really, and we often look towards non-insured health benefits or accessing that kind of lane through healthcare. So we really need to decide, you know, like when we're moving forward with virtual care, I absolutely agree, it cannot be the only form of care being delivered. But where is that cultural competency part? Who is evaluating it exactly? Like what was said before, and how do we change it from, yes, we are, as a nursing student that went through nursing school, we are constantly told patient-centered care, patient-centered care, but when we actually go into our clinicals, when we work in those institutions, it doesn't really seem like that. And so we need to take another step back and look at the sustainability of it. And I know that's kind of what we wanted to touch upon, but if we look at the sustainability aspect of healthcare, is that inherently decolonial, or do we need to deconstruct a system that was built to kind of put us in that assimilative position? And can we even deconstruct a system that is inherently colonial? So we need to ask ourselves those questions, and we really need to commit to that responsibility of deconstruction and decolonizing as healthcare providers, as people who work in anything that touches upon healthcare, because that is our right as a person, as a human. And I guess the second thing I did want to touch upon too is harmful research. So when we're doing all these amazing things, and when we're going into the communities and talking to the elders, talking to the community members, how are we doing so in a good way? And I know that there are OCAP principles that do exist. There's those ethics committees. There's a lot of different modules we have to go through before actually visiting the communities. But even then, is our research harmful? So I think a lot of the process is a reflective process on oneself to kind of place themselves in this virtual care world. So knowing that, yes, rural and remote communities might not have the same access, but is that only limited to Indigenous people, or are there other systemic barriers in place that continue those assimilative tactics, right? So we have our own teachings, we have our own healthcare models. Would they suffice in the virtual care world? I guess that's another really good question. And then as someone who was on the board of directors for a lot of Canadian nursing associations, just as a student, and talking about competencies, you know, a lot of it is smushed into 4 years. And I really believe nursing should be like a 5-6 year degree. But we need to kind of take in the headspace for curriculum revamp. How do we indulge in the virtual care of that without clinical, right? So if we're in hospitals that don't have access to those certain technologies, then it's really stunting the learning curve of certain nursing students. And then that means that across the board, across all provinces, we don't have the same care. So I think that's just some food for thought. But I really do think that that there is some strength-based focused work that's being done in virtual care, considering students and Indigenous communities. Yeah, thank you.
Thank you, Victoria. Mathieu, you've been listening to all this. You come in with your perspectives from a patient perspective and what you've heard and what you've experienced. Is virtual care a good thing, a bad thing? We sustain it. What do you like about it? What are your perspectives?
Well, lots of good points were made by everyone. I think that, well, I will maybe start from my own sort of perspective as someone who lived with hemophilia his whole life, which is a genetic disorder. And so you're born hereditary. What happened in hemophilia is that as technology advanced, hemophilia in, let's say in the 50s or 60s was a very debilitating illness. So people with hemophilia would spend many, many weeks in the hospital. They had special rooms actually in the hospitals for people with bleeding disorders because the treatments were very inefficient. It was plasma, blood infusion, and then plasma infusions that were very, very slow to act. So it could take 6-7 hours before someone would coagulate. Meanwhile, they were bleeding inside their joints and in their muscles. And so anyway, so people with hemophilia from that sort of that generation before me had were really like slaves to the healthcare system and to hospitals. They were there all the time. And as new technologies appeared, they were graduate. So they were basically what do the new technologies allow is for patients to leave the hospital, for patients to have their own, to be able to live emancipated lives. This is what the technologies brought. So the coagulation products, they unfortunately also brought along the coagulated blood crisis. And so that spurred a patient engagement within the healthcare system. And then from then on, we could say that healthcare given to hemophilia patients is really something which is co-constructed in the sense that patient community is involved in the healthcare given to hemophilia patients in Canada and in many developed countries. And then more recently, we saw applications and online database, like digital databases for patient data. So it's called CBDR, the Canadian Bleeding Disorders Registry. And so there was an application created, which was a patient interface into this bleeding disorders registry. The registry itself was a project that came from the community and then was applied by the healthcare professionals. But what did this application give? It gave more tools to patients in order to give them greater autonomy and greater tools to be able to better manage their own illness and be even less dependent on the healthcare system. So what I'm trying to get at, and I think it's sort of along the line a little bit of what Ewan was saying, that we have to really rethink. I don't think that technology should be an end in of itself. I think that we have to really see it as just tools, opportunities, but we have to rethink the way we have to rethink healthcare. And I think that you can look, so I used hemophilia as a case study to sort of introduce my point, to say, look at this, because it's the one I know the best, right? But look at how over 60 years, what did the technology had a huge impact on the life of people with hemophilia, but what happened? You know, where did they go from being in the hospital for weeks at a time, bleeding internally? What are they doing now? They're not going to the hospital. You know, they're living their illness in another way. And so that's what we try to teach when we teach patient partnership. We try to teach a new way to consider the role of patients and families that live with illness and that have to interact with the system. And so I think that we would be making a mistake if we thought that these new technologies would be sort of a remedy that would instantaneously. And I love the example of Ewan, who, I'm sorry, I'm not pronouncing your name very well, but who said that they're still using the phone, and I find that incredibly that's incredible to me, because it would seem like that would be the most obvious place to use these new technologies, right? So, and regarding Victoria's point, I think that, well, we had, of course, I cannot, identify as First Nations or anything, so I can't really talk to that much. But the patient partnership model of care tries to move away from a more paternalistic model of care. And one thing which really touched me recently, we had a tragedy in Quebec in Joliette, where a patient, Joyce, was unfortunately passed away because of bad care. And I was unable to listen to the whole video, but one thing that I overheard from one of the healthcare professionals was, they said in French, "You are not able to take care of yourself, so we're going to take care of you for you." And that for me was, in one phrase, everything that was wrong with the paternalistic healthcare model. And so that's something that, anyways, I hope that I like to think that we're somewhere on the right track in teaching more of a partnership model of care. In any ways, for me, that's a direct representation of what we're trying to move against.
That was interesting, yeah.
And so patients being more autonomous, partnership in care, and this leads me to, I think, moving away from a hospital-centric healthcare model. I think that that's one thing that the new technologies can definitely help. I think that that's what hemophilia patients, generations of hemophilia patients, went towards. And I think that the hospital-centric way of organizing healthcare is also closely attached to a sort of a paternalistic way of thinking in silos. You also mentioned interdisciplinary collaboration, which is problematic. That's also something, I mean, I know I'm putting a lot into one intervention here, but I think that we have to really rethink the way we give care in society, go back to more of a human relationship. And when people think, well, what is a hospital-centric? It's something which we sort of take for granted. But what was there before that? Care happened more in the homes. It happened in the communities, with the communities. That exists. Yeah. And I think we have to go back to that.
Yeah, it's an interesting point. And I know when we were talking last week in Afghani, you sort of talked about, do you remember at one point you had to have a relationship with your banker, and heaven forbid if you didn't have a relationship with your banker, and now people don't have relationships with bankers, and there's that changing technology. But I think that technology allows people to take more control and have more information and be able to do it. But we need to make sure that the system keeps up with, or doesn't create barriers, systemic or otherwise, to be able to access that care. Evgeny, you took yourself off mute, so I think you want to make a comment, and then Sandra, I'd be interested in your views on that as well.
Yeah, I really want to build up on something that Ewan said, that there is a technology out there, but we are using it in a very analog way. And I want to refer to something that was done as a study in US a couple of years back, and then actually they found that 55% of physicians' time is being spent in data entry. I mean, imagine, this is precious time. And doctors are just using technology, entering in computers some data. And today, if you think technology with NLP, natural language processing, and virtual care, that conversation between a physician and a patient can be automatically recorded, can be transcribed, can be codified, can be put into the documentation without spending a single minute of that doctor that has to just sign a document. So there's plenty of opportunities in technology. We just have to use it in the right way.
Yeah. Sandra, from a government perspective, and we think that overnight we switched, and I should just remind people listening to this conference that we did find, when we say virtual care, we mean video, phone, and email and text. So anything that's not face-to-face, basically. But we are finding that 67% of the virtual care is actually being delivered via telephone. So, and you're probably seeing that, Sandra. So, you know, from a government perspective, are we moving fast enough? Are we perpetuating the, you know, we have a systemic level, we have an individual level. Where do you see the conundrum or the disconnect?
Yeah, so I think there are probably many, and you know, I too, like you, and have been, you know, in this business for a long period of time, trying to move this forward, and you really try to sit back and think, okay, where are the disconnects? I think one of them is we started talking about technology, and we didn't start the conversation talking about we want to solve or need to solve a problem. Multiple problems in the health system, in fact. And so if I think we need to stop talking about technology and start talking about access to care, access to service, access to providers, the sharing of information, provider to provider, provider to patient, patient to provider. So we really need to position this as solving the real problems in healthcare. I also think, you know, people are really nervous about changing the traditional healthcare system, right? Whether it's working or not, I think people are challenged to really sit down and think about it. And you, and one of the things that you said is, you know, we fail in Canada because we have not reimagined healthcare. I'd like to flip that to a little more positive, to say, in order for us to succeed in Canada, we have to reimagine healthcare. And part of that reimagining healthcare is, how do we do these things differently? And then we go, oh, look, it can be technology that can help us, right? After we reimagine how we can do it. Then there's the how do we do it conversation.
That's a great point. And you and I'll come back to, there's a couple of questions I wanted to get to those, but I just want to sort of come back to you and just one more time, because I think one of the things, and you talked about it, Sandra, is that, like, I love that idea about reimagining healthcare, and technology is a tool about which, once we just reimagine what it is that we want. So, you know, you, and from your experience and having listened to now this conversation, what do we do to get from where we are? And I think it's that, you know, what do we want to have as patients? What do we need to deliver quality care that you talked about, and that continuum? Because I would argue that I have had the same doctor for 10 years. I don't have a relationship with my doctor. I see her for an annual physical, and I'm fortunate to not have to have a relationship. I thank God every day that I don't have an intimate relationship with my clinician, but a lot of us don't, even though we have had the same thing. So that continuity of care, I don't know if is that an old-fashioned notion or not? Anyway, I'm just curious about your perspective on that.
Yeah, I keep nodding here when all the different people are saying things, and thank you all for many interesting comments. And yeah, continuity of care comes in many different forms. I mean, there's relational continuity, there's informational continuity, you know, and I think in the current format, given the nature of the business, that we're looking more at team-based continuity as a realistic sort of entity. But there has to be continuity, or there should be. It should be an aspirational thing in some way, shape, or form. And every study in the literature supports that if you have continuous care with some service in some way, shape, or form, that the likelihood of your outcome being better increases. So, and that gets back to the whole design around quality of care. And so, you know, and thank you, Sandra, for, you know, I'm a firm believer in identifying problems in order to solve them. And I still believe in the value of technology, and we will need Evgeny's to help us with the technology, but we have to understand our relationship to it. And to you know, with Mathieu and Victoria, first of all, I tip my hat to Victoria. Structural organizational healthcare continues to be used as an assimilation tool. I'll just say that, and I could not agree more with my 30 years working in an Indigenous context, but that's a whole other side. It goes well beyond digital health. But if you look at health information system design in Canada, it is not designed around the patient. It never has been, it isn't, and we all pay lip service to this. Oh, it's patient-centric. You just have to do an analysis of of information flow around any clinical case, and you will rapidly understand that information systems are designed around services. Mathieu said hospital-centric, whatever, whether it's a clinic and this physiotherapy clinic and that ophthalmology clinic and whatever. We have designed our digital solutions around ourselves. I'm a provider, not around the patient. What that does is, what has resulted is that patient information has been fractured across the system. That's why in Ontario, for instance, there's about 100 different patient portals now. Does that make any sense to anyone in terms of an investment or a coherent and unfractured system? Probably not. So we have a huge problem that needs to be reimagined. The Supreme Court of Canada decided in 1992, McInerney versus McDonald, that the owner of health information is the patient. Do we act in the industry like the patient owns the information? Do any of us as patients feel that we own our information? Absolutely not. And this is not a theoretical or a legal issue. It fundamentally is an informatics issue, because if the information that someone like I, moment by moment, uses to adjudicate the care of someone, follows them through the course of their healthcare experience, I will likely make better decisions if I actually sort of know what's going on, let alone it be more efficient and so forth. But I don't half the time, because it's broken up all over the place and you're searching for things and it's chaotic and it's leading to burnout and unsafe care and so forth and so on. So we need to reimagine. So the optimistic thing is, I honestly believe that Evgeny and his crew are going to provide us with technology that can really make have a profound impact. I believe in that. I believe that sorry, and then so I'll just finish because I'm monopolizing. So we can do this, but we have to design ourselves and reimagine ourselves in order to profit from the potential of the technology. Sorry, Sheila.
No, that's
a
great.
little excited.
And I think, well, and this could go on all day, and we've got about 10 minutes left. We've got 3 or 4 questions in the queue, so I do want to go through them and give, to respect the people who took the time to ask the questions. And so we'll have to keep our answers fairly brief. So it's an interesting one. It sort of relates to what we're just talking about. So do you feel virtual system might have failed us in addition to lack of literacy and infrastructure? So the question is, some of the technology has been developed with other interests in mind, and not necessarily healthcare professionals' use of the system. So right away, the question is about healthcare systems' use of the system, but it's interesting. So, maybe Evgeny, some of the technology has been developed with other interests in mind. Your comment.
I would agree totally. I mean, even if you look at at some of the health information systems, they were developed actually for not providing healthcare. They were developed for billing purposes. They were really for a completely different purpose. They actually went into clinical space just before that. And this is why, even is totally right, they are centered around a case, a specific episode, which happens obviously within a healthcare acute setting. So it is done with a different purpose, and to do it really from a patient-centric approach, you really have to start thinking differently. And you really have to start thinking probably in a more holistic approach that actually puts together not only the health data, but think about lifestyle data, think about wellness data, various kinds of other data points that are so important in actually creating something that looks and feels differently.
Right, and by the way, co-design it with patients who are the experts in the healthcare. Yeah, this question I think is yours, Victoria. Powerful words and questions we all ask ourselves. How can we as healthcare partners and providers set ourselves up to be better listeners and engage as patients with Indigenous communities and Indigenous patients?
That's a loaded question, but a really good one. So I actually do get asked that a lot, depending on the environment in which I'm working in. But I think, as I mentioned, the reflective process is so important, and the means in which you're able to educate yourself on your own time without putting it on to, let's say, an Indigenous healthcare provider, an Indigenous patient, or because it's so much more than being open-minded, right? There's a foundation of understanding that we need to bring to the table if you're an ally, or if you consider yourself an ally, or just as a non-Indigenous person residing on Turtle Island, we all have a responsibility to each other. And, I think a lot of it is what are you able to commit to as an individual? What are you able to truly, truly commit to in your learning journey to Indigenous people? Because we do have to remember, this is whether it's treaty or unceded territory, we're living on Indigenous land no matter where we are. And the land is inherently connected to the individual Indigenous person. So we carry that, that very intrinsic feeling of being connected to the land. And when we were ripped off the land, we lost our way. We lost our Mino Matsuin. We lost our teachings. And so we're hoping that you're gonna be there beside us, guiding us back on our journey, on our path that we need to be on. And so I think a lot of it, you know, like I did mention harmful research, but that's more extractive. That's more when the intent or the goal of the program or service or development is not specific to that community, but serves a greater purpose that might not include the community in the end goals, right? So there's a little bit of like miscommunication, they would say, but it's really tokenism is what it is, right? And we tokenize these communities as a part of harmful research, but if we could take a step back and really develop authentic relationships, there's no book, there's no manual about that. It's all about how we're able to self-reflect. So I hope that's a good answer.
Yeah, great answer to a tough question. No question. Thank you. Next question, do benchmarks exist? How will we know if we've really nailed it or possibly using a bad model well or a good model poorly? Anyone want to tackle that? We've got a couple of others. That's the easy one.
I'd just say the benchmark needs to be indices of quality care for designing effect. The purpose of digital information is to improve quality of care, or at least keep it the same. And so that's a difficult thing to measure, but that needs to be the measure.
Okay, let me jump to the next one. How do you get to a centralized patient-partnered defined goals of care that the care plan is built around? How do you get to a centralized patient-partnered defined goals of care that the care plan is built around? You know, it's an interesting comment, and you know, one of the things I was thinking about you and when you talked earlier about the patient, the one thing that is consistent among the different episodes of care is the patient that travels, right? So the data. Anyway, Afghani, were you going to take a crack at this one?
Yeah, let me take a shot at this one, because we have seen one very interesting project in the Supercluster, and it's a reflection of the fact that when the pandemic struck, all the different health systems, all different providers, they came up with their completely separate protocols. Everybody has been working on their own. So a very interesting project started in just making them collaborate, basically, just like a Wikipedia, share that knowledge, start co-creating some of those together, borrow something that has been done in another provider, in another health system, and just tune it, but don't rebuild everything from scratch. It's a very simple, just like Ian was saying, it's just democratizing medical knowledge. In today's world, this is so, I would not say easy. It is not that difficult to do.
Yeah, that's a great, and I'll end it there because we are out of time, but I think that's a great summary. And I do want to thank each of you for taking the time today. Really good discussion. This could go on. We knew this was going to be a really good and rich discussion. I think, you know, the conclusions that I'm sort of hearing, if I have to do a reflective summary of the discussion, is that we really do, technology is a tool. Virtual care is one method. We need to make sure that we have the system right and reimagining healthcare. And I like the way you put it in your optimistic view, Sandra, around what is the right thing to do? How do we make the system truly centered around the patient and the care episode, or not the care episode, the continuity of care, and then using technology as a mechanism and a tool to enable that to happen. So thank you so much to Victoria, Sandra, Ewan, Matsir, and Afghani. Really, really appreciate you taking the time out this afternoon and joining us here today. And with that, I think we're on a break. So we will break for 5 minutes or so, and we will reconvene at 2:25 for our closing keynote. So thank you again very much.
Well, welcome back, everybody. My name is Catherine Seeley, and I am the director of the patient engagement portfolio within TELUS Health. And I'm delighted to have the opportunity to welcome Dr. Indra Joshi. Before I do, I'll just give you a little bit of background. And this final point and session is about artificial intelligence, which, as we all know, has the potential to transform many aspects of patient care. And it's already complementing the skills of our medical professionals to provide diagnoses and treatment recommendations. Medical experts are using deep learning algorithms to analyze countless patient records to diagnose heart conditions, detect cancer, identify eye disease, even at the earliest stages of the disease, and with incredible accuracy. And AI is also being leveraged to monitor seniors and patients at home with chronic conditions, enabling them to be appropriately cared for in the comfort of their homes for longer. AI is also improving patient engagement, as we heard in a previous session today, helping individuals have better empowerment on understanding their health outcomes with the influx of new applications and tools. And as TELUS being a provider of personal health records, we're very much planning for the proliferation of more of those AI tools and connecting them to our PHR in the provinces where we support patients' personal health records. In addition, there's no doubt that we're going to see more and more AI use, and it will explode in the years to come. And the question becomes, how do we handle this new information responsibly? So now for the expert, I have the pleasure of introducing Dr. Indra Joshi, who led the creation of the National Health Services AI Lab, which was launched in 2019 to accelerate the safe and effective adoption of AI in healthcare in the United Kingdom. Dr. Joshi's other responsibilities include overseeing digital health initiatives within the NHS with a focus on data, health standards, and evidence. Indra has a unique portfolio of experience stretching across policy, digital health, national project strategy and implementation, whilst also remaining true to her professional training as an emergency medic. She is also the founding member of One Health Tech, a network which campaigns for the need and importance of better inclusion of all backgrounds, skill sets, and disciplines in health technology. So without further ado, welcome Dr. Joshi, and I look forward to your presentation. And you're on mute.
Brilliant, I'm on mute, classic. Isn't that great introduction? Thank you so much, and hi everyone. I'm Indra, as Catherine has introduced. I'm a doctor by background in emergency medicine, and now my role is overseeing something called the NHS AI Lab, of which I'll tell you a little bit more about as we move on. I'm conscious I've got some slides, so hopefully you can see them, and I will, there we go, perfect. Now you can see them, and I will run through them as we talk. If you've got any questions, I think just pop them in the chat, and hopefully we'll have some time at the end to cover them. I always say this at the beginning of these things, it's just so incredibly difficult doing these things virtually, because I'm here by myself in a room, talking on a screen to nobody. But hopefully what I say will be relatively interesting and helpful for colleagues on the other side. So I've put the website there, and everything I say will be quite brief. There's a lot more content on our website. Please do take a look. We've also got a virtual AI hub, a community there for colleagues who'd like to join and find out a bit more, and also discuss with fellow experts in the community about some of the concerns or some of the work that we're doing. So I'll just give a brief overview of who we are. NHSX, we're a new unit. For those of you who may not be aware, we started off formally last year, July 2019. And the idea was in the UK and in England in particular, so we're 4 nations under the umbrella of the United Kingdom, but we have separate NHSs, so to say, health systems. So in England, we decided to join both the policy unit from the Department of Health, our central government, and one of the delivery operational units, what we call NHS England, which commissions services. So effectively is what we call a buyer of services and care pathways, to join together. And we formed this unit so that we could better link what we were doing both as a policy, but also as a delivery. So it would provide more consistency and a better narrative to those people wanting to understand more about the digital transformation agenda. So as I put forward on the link previously, nhsx.nhs.uk is a link where you can find out a bit more about NHSX. And as a unit, we have a number of different programs. Here on this screen, you'll see an outline of some of our core missions. But the idea is very much, how do we use digital transformation, digital technologies, digital health and therapeutics, as well as that background infrastructure to actually enable both patients, carers, but also healthcare professionals better deliver care and better understand the products out there to enable them to deliver care. So as you can see, we have 5 missions. I won't read through each and every one of them, but you can see that we're there to both provide an infrastructure and help with an infrastructure, but also on the front side, ensure that we're improving health outcomes with digital health and technology. So I'll go on to talk a little bit about the NHS AI Lab. So this is a program or programs of work that we oversee in NHSX, but we do it with multiple different partners. And our core mission statement is what you can see here. It's not necessarily about improving the development pipeline, but actually about ensuring that there's a safe adoption. There's a lot of noise around AI, but what we wanted to make sure was that actually when it gets deployed in the front line, in whichever setting that might be, in a hospital setting, in a care home setting, or in a primary care community setting, that it was a safe setting and that it was doing what the technology said it would do. So our tagline is accelerating the safe adoption of AI into the front line of health and care. We have a number of programs. So we're a 250 million investment from the government into the program. And what we are is split up into broadly 6 areas. And I'll go through each one in turn over the form of this call, this webinar presentation. Ones people may be aware of is essentially when we're, it's great to be able to say, oh, look, here is AI, here's the technology. But a lot of the time people will find that actually investing in these technologies is the key area. And what we mean by that is not necessarily just investing in the early development of them, but also into the later stage, into the deployment of these technologies into the front line, as we said, because quite often care systems, and especially here in England, we haven't quite found a way of paying for them. They may be in a slightly different category. So how do we ensure that we pay for them? So the reason for setting up this Health and Care Award was to initially say, well, let's provide some money up front to figure out how we, what we call commission these services or these products moving forward. Out of that system, we also need to ensure that we support that system. So we ensure that the rules of the game are right. So we've also developed a number of programs with our regulators. We have a number of regulators here in the UK. Some of them colleagues may be familiar with, the Medicines Health and Regulatory Authority, we call it the MHRA. We also have another one which looks at services into the front line, we call it the Quality Care Commission. And so again, we've worked with these different bodies, these arm's length bodies, to say, how do we bring together programs of work that enable you to develop what you need to help us support some of the products that we're funding through the Health and Care Award. Now I'll just go through the different programs of work as we go in. So we talked a little bit about the Health and Care Award. The idea of this is we've taken quite a large chunk of the funding from the AI lab as a whole and put it in here. So this is 140 million we've invested over 3 to 4 years in this space. And the idea is to say, if you're developing a product that's either early stage, so you're still acquiring data, you're still building your models, and you're trying to understand maybe a high level hypothesis or research question, we want to hear from you. But at the same time, if you're also developing something that has been market ready in a different country and you want to deploy it here in England and the UK, how can we help you deploy it in multiple sites? And the idea about doing it across multiple sites is to say, well, how do we evaluate that? And then how do we commission that as a service or as a product longer term? So this isn't just about a short, sharp, here's a bit of money and then we're leaving you alone. This is about saying, let's give you some money, let's work with you nationally, but also from a regional perspective, and then understand how do we commission that longer term. And we were really delighted that in the first round of the award, which opened up just before the pandemic hit. So we opened up round 1 in January, and we had over 500 applications. And of those, we've selected 42. More details of each one can be found on our website of the different phases. And currently we're open for a second round of applications. And we heard quite clearly from the system, especially following the pandemic, that it was great to invest in the earlier stage products, but actually here, the system, we're a national health system, and it is under a lot of pressure. And a lot of people were saying, well, surely there must be some AI technologies that can help us now, in the here and now, to help us through this. And so what we've done this particular time with the round is to say, are there any technologies in either triage or process automation, which some may classify as not purely artificial intelligence, which academically I would agree with, but to say this is about alleviating the burden on frontline practitioners right now in this current climate. So we're really happy that we've got this funding through to enable this. And this has enabled us to learn quite a lot about how we actually do the nitty-gritty of both contracting with companies, ensuring that the data flows properly, but also then how do we implement it into a care pathway? Because it's all well and good having a product over here, but if it doesn't implement into the care pathway, so I as a clinician, when I go to my computer, can see the AI model working in real time, that's what we're working with this AI award to. The second program of work we developed during the pandemic. So one of the key things, and I'm sure colleagues on the phone will have heard this as well, was there are a lot of companies who are developing some brilliant technologies. And actually imaging was one of the key areas where we developed, we've seen a lot of developments, and there are a lot of companies out there that have market authorization, regulatory approval to do image recognition. And so one of the things we thought we'd start trying to do is pull together a set of images into what we're calling a national database. So we've called it the COVID-19. So we've pulled together chest images. This is across multiple modalities, X-ray, CT, MR, to pull them together to allow companies both to train on those data, so to allow them to build their models on UK sets of data, but also then to try something that we've talked a lot about in the literature, what we call validation of that model. So technically, is that model what it says it is? And what are the different data quality, data standards, data integrity that we need to ensure that we can validate that? And so we built this chest image database. It's there, it's running, it's live. We've got a GitHub account where you can access a lot more information on the different types of data available, both to access and train models, but also, as I said, to start trying how we validate. So this is quite a key area for us. And on the back of the chest image database, we did a lot of work with all of our stakeholders and realized that actually this is a key area to both train and validate, but also then to deploy. And so what we're looking at now, we're going through a formal discovery, is how do we actually create what we call an imaging platform for the NHS. The next program of work that we've got in the lab is something called a skunk works. I won't delve too much on this. This is a slightly internal program of work, but the idea is that with every big national health system or a big health system, you have problems internally as well with your business, with the way you function. And how can we actually put some both technical skills, but also strategic skills to help teams within the organization solve problems that we have already. And some of the areas we're looking at, for example, might be the workforce, and that's one we're exploring. And another one we're exploring is around accountability and liability. So how can we use AI techniques to help some of our accountability regulators, they are named NHS resolutions here in the UK, but actually deal with some of those issues and use AI to help them during their internal processes. So an exciting piece of work, but a very novel piece of work, the skunk works. And then moving on, I talked briefly earlier about the regulatory aspects. It's all well and good putting money into the system and building products. It's exciting to build products. People always want to hear about products because that's exciting. But actually the underlying foundations are incredibly important. And one of the key things we heard from innovators, developers, but also commissioners was there are a lot of pathways and there are a lot of bodies around there. How do we actually navigate our way through these? And why isn't it clear? You know, we don't want to go through to 7 different areas. We just want to have a very clear pathway. And so what we've done, as we've highlighted on this slide here, is work with a number of the different agencies that we have to both create as kind of almost like a front door one-stop shop for AI advice and regulation, or data-driven technologies and regulation, ensure that there's a streamlined review. So colleagues on the call may be familiar with NICE, our body, which stands for the National Institute of Clinical Excellence. It's quite renowned for its evaluation and critical appraisal of drugs and medical technology. And what we're doing is working with them to also develop guidance and a critical appraisal pathway for AI technology as well. And the next thing, which is also very important, is something called the yellow card. Clinicians on the call may be familiar that here in the UK, we have quite literally a yellow card. It's a yellow piece of paper that you fill out if something goes wrong, predominantly with medicines and diagnostics. And how do we actually turn that from a kind of a physical piece of paper into a technical care pathway? So it slots into what is actually happening on the front line of the care pathway. And then what may be more interesting is also the work we're doing internationally. So what we're doing is slotting into these programs of work. We're by no means leading on them. Colleagues may be familiar with the recently published Spirit and Consort AI guidance. This was really critical, especially from a clinical trials perspective, and we've tried to incorporate these guidance into the funding structures that I mentioned in the AI award. But again, it's to provide some consistency and clarity to researchers to say, okay, when you're publishing your trials, what is the guidance for publishing in this space? The WHO and the GDHP, so the Global Digital Health Partnerships, these teams are both doing quite a lot of work around both benchmarking of AI models, but also about looking at the regulatory aspects, the ethical aspects, and saying, how do we provide guidance and checklists? And in the NHS AI Lab, we're contributing a lot to these different programs of work led by the two communities, but also we've the GDHP commissioned a kind of a global policy on what is the AI policy out there. So do look out. We've got a report coming up with them on what can help build a more formal AI policy internationally. And then lastly, there's always a lot of noise around AI. And one of the things we wanted to do was start pulling together resources both in the UK, but also internationally that were good and that we felt actually helped to inform both developers, develop products, commissioners, commission products, but also users who may be, oh my goodness, I've lost all my words. I was on such a flow there. Users who want to understand a bit more about what AI does, what it means, how can it be used. So just broadly around the periphery of the topic of AI to actually understand a bit more about like, what does it mean? Why would I be caring about it? What can it really do for me? And so we put quite a lot of resources on our website. Some of them are health related, some of them are broader than health. They relate to AI in general. Some of them are very specifically around the ethics of AI, because this is vitally important and a personal project that I feel very passionate about, and making sure that the diversity and inclusion of data is there. So I'm very conscious I've given you all a whistle-stop tour of what we're doing in the healthcare specifically in the UK around AI, and I've also given you a very England perspective. There are different programs of work happening in Scotland, Ireland, and Northern Ireland and Wales, but hopefully that's given some food for thought. And I'll pause there for any questions and hand back to you, Catherine.
Actually, it's going to be back to me, but thank you very much, Dr. Joshi, for that wonderful presentation. You know, it's always really useful to have an English perspective, I think, because there's so much happening here, and culturally there's so much convergence, I think, with Canadian culture still. So I think that it really is very applicable. Now we do have time for a question here, I think. And somebody is wondering, would the standardization of treatment and examination procedures in every specialty of healthcare be helpful and increase accuracy, in particular when AI should be applied?
So we've been thinking about this quite a lot, and I'll give two kind of concrete examples where we've had slightly differing opinions. So one would be dermatology. Colleagues may be familiar, there are a lot of what we call teledermatology apps out there, which currently at the moment triage. So they triage you to say this is urgent, not urgent. And if it's urgent, go and see your practitioner now. If it's not urgent, go and see them in a week. So triage by time. But they're bordering using image recognition techniques on being diagnostic. So saying your mole may be cancerous, maybe not cancerous. We don't quite know. Go and see a healthcare practitioner who will confirm that. So from a dermatology perspective, now I'm not a dermatologist, so I'm not going to try and answer all the questions. There are some very specific areas that you are interested in and want to standardize. Now, on the flip side, if you're a radiologist, so we've spoken a lot here in the UK, we have a national breast screening radiology program. We've spoken a lot to radiologists who look at mammograms, and they feel there's a slightly different technique there, because yes, it's about reading the diagnostic image, so reading the mammogram, but also then about knowing what the next step in that care pathway is, to biopsy, not biopsy, when to biopsy. And so, yes, there are some common underlying standards which most colleges and most practitioners feel should be there. And one of the things we've done is, it's still hopefully being updated, but we published a code of conduct, or a guide to good, which we're calling it, which kind of underlies all the sort of basic standards, one might say, when producing these technologies. But the next level above that, almost talking about the evaluative critique, or looking at what we would call prospective trials, that may be slightly different for each specialty. And that's something we're working through now with different, we call them Royal Colleges here in the UK. And also I mentioned NICE, our National Institute of Clinical Excellence, which does these critiques more formally, to say what would be the standards, what would be the evidence requirements once you've got the basics, but you've put it into real world practice and you want to figure that out.
That's great. Now we have another question coming in here now. If you have an opinion on AI as a service concept in healthcare platforms.
Yeah, I mean, we see this quite a bit. I mean, it's one of the things we've seen is from a primary care perspective is, again, a lot of these are kind of, we call them AI, but very simply, some machine learning algorithms, which utilize both triage and then symptom assessment as a service. So they are there. There's a lot on the back end. The work we're doing with imaging, again, is starting to look at service platforms. So I think there is a lot of work operationally. We've seen a lot of work there as well. I talked about process automation, but there is a lot happening. And we work with a number of providers on that. So I think yes is the answer in brief.
Now I have, and I hope this is okay, but one of my own questions for you, since I'm seeing that we have just a couple of minutes, 2 minutes left here. What do you envision in terms of incorporating people's digital health records across silos? You know, the health system is so segmented. Are we able to eventually use AI to say, look, we have risk factors here across practitioners who might not know that there are risk factors here, to be able to present a more comprehensive picture of the patient?
I mean, the utopian answer would be, we hope so. I think there's a number of challenges, data standards, interoperability, APIs, all the rest of it that we still have to get through to get there. What we are seeing now is, I mean, it's so difficult when you say AI to help. If you narrow it down, and you take, for example, a rare condition or a condition that is not so easily recognized at first presentation. And for example, I'll take endometriosis. You know, a lot of women suffer from endometriosis. It's not an obvious condition when you first present, but actually if you looked across it, across the multiple different hospital presentations, there are patterns that you would see. And we are seeing companies start exploring those. I've given endometriosis as an example, but there are other conditions that are slightly less obvious on what we call first presentation, which when you put them all together as a pattern, which AI is very good at, does pick up. So yes is a short answer. We'd like to see that in the future. I think practically you probably have to boil down to taking a couple of key case examples and working them through and really understanding what those mean. And obviously there's always the kind of the cost benefit ratio of investing in those. One mustn't ignore that. But yes, that would be great in the future.
And it'd be fascinating to see how, from previous presentations that we had in prior iterations of this webinar, how this interfaces with wearables and with other technology areas as well. Thank you so much, Dr. Joshi, for joining us today. It's been a real pleasure and an honor learning from you.
Brilliant, and thanks for having me. Thank you.
Now, if you missed any parts of our presentation today, or if your colleagues are asking, the recording of the event is going to be available by the end of the week. So please watch for the wrap-up email in your inbox. Now, I really want to share how much of a privilege it has been for me over the course of the last 3 sessions to be able to have these conversations with you. You know, not only as a mental health professional and advocate, but as I mentioned at the top of the show, as a person with lived experience, as a patient, to be able to see the kind of innovation, the kind of connectivity that we're seeing happening right now in the digital health space is inspiring, to be frank. You know, we've had healthcare delivered the same old way for so long, and I think on the patient-facing side, we really haven't seen the kind of futuristic developments that we're seeing now. So my hope is that these developments are sustainable into the future, that we continue to grow, that we're picking up steam, because really patients deserve this kind of innovation. Now, as you know, the final segment of the Fall Partnership Fall Series is taking place during Digital Health Week. This awareness campaign celebrates the difference that digital health is making, something that many Canadians experienced during the pandemic as they were able to safely access care using virtual options, and this has been an incredible development as well. Digital Health Week is supported by a number of healthcare organizations and led by Canada Health Infoway, so thank you, Infoway, for that. By being here, you're joining a national conversation on how digital health is transforming care. And throughout this event and the week, you can share your thoughts using the hashtag #ThinkDigitalHealth. So pop over to Twitter or wherever you're using your hashtags, Instagram, Facebook, wherever. You can tag me if you want. I'm on there too. And hashtag those thoughts, #ThinkDigitalHealth. There's a number of events taking place all week, so I want to highlight just a couple of them for you right now. If you're on Twitter, you can join the Children's Health Care Canada and the hashtag HCLDR community for a tweet chat that'll be tonight at 8:30 p.m. Eastern. I'm going to be on there for that as well, so let's get on and have a bit of a conversation there. You can also check out another Infoway webinar that's going to be coming up on Thursday, where you'll hear an international overview on citizen access to personal health information. This is really key for people to have access to their own information. We'll be joined by the Global Digital Health Partnership collaborators from the Netherlands, Estonia, and Canada. Panelists will share different approaches and solutions to citizen access to personal health information. It can be incredibly empowering. Just as a side note, I was able to do that myself as well, to have access over my own information. Now, finally, Infoway would like to take a moment to acknowledge the recipients of this year's Women Leaders in Digital Health Awards. The winners for 2020, you see them up here on your screen, were announced recently by Digital Health Canada. And this award celebrates the top 10 female visionaries who are harnessing the power of IT to transform health and healthcare in Canada today. So congratulations to this really incredible group of women. Just as some final thoughts as we sign off here, I want to thank you all for absorbing this information today. You know, it's not always easy, although I think we're getting more and more used to it over these past 9 months and who knows how much longer, to engage in these kind of meaningful sessions in this kind of way. But I think as we get the swing of it, as this adoption curve, as we all ride this adoption curve to consuming information more meaningfully in this way, I think we're all better because of it, actually. So maybe that's the silver lining, that we have so many more of these wonderful opportunities to educate ourselves and to improve our practice. So I'd like to thank you all for joining us for this series, and a happy Digital Health Week to you. Thank you to the panelists, to the sponsors. I'm Mark Hennick, and it's been a real pleasure. Take care.